problems with slides. Welcome to this session. I have to apologise that Melissa Leach isn't able to make it, so we don't actually have a discussant. But judging from this morning, I don't think we'll have a problem in having kind of lively discussions about the contents of the papers anyway. So we have quite a few papers to get through, so we'll start now and I think take just very brief questions of clarification if anyone has them after each paper, but preserve most of the questions for the end so that we have a panel discussion, and we're lucky to be able to have everyone sitting there and available for that. So I'll introduce Gerry Bloom to start with. Thank you very much.
I'm Gerry Bloom. I'm based at the Institute of Development Studies, which is just on the campus here. I'll try. In the post-colonial, and I'm thinking partly how we talked in the morning, there was a vision in the post-colonial period or post-revolutionary for China or Vietnam, and it was that the state would lead the creation of a modern health system. And it looked something like this. R&D would take place in a few centers of excellence, but other countries should ensure their population benefits, and that the benefits of this R&D would be made available globally. There'd be procurement of drugs from international producers, or maybe, as we saw, some countries would produce locally. So this was the vision. And I put here China, India, Bangladesh, for ages were producing locally. But they weren't seen to be the source of R&D. And they'd be distributed largely by a monopoly public health system, kind of the extension of what all of us who've worked in the post-colonial periods, the central medical stores. So there'd be a central medical stores procuring drugs and distributing them. And then there'd be a government health service who would control access to the drugs, so they'd be used appropriately. And there'd be publicity campaigns to inform people of their entitlements, encouraging them to adhere to treatment regimens and increase accountability. And when I listen, even this morning, to the language of global initiatives, they cling to this vision of basically the global spread of a state-led modern health system. And there's a bit of sorrow that hasn't quite happened. Now, what do I see when I do work in low and middle-income countries on health systems? Pluralistic health systems with a wide variety of types of providers in terms of the training, the relationship to regulatory frameworks. They're almost all engaged in market activities, whether they're government employees or not. There's a segmented health system, and the poor mostly rely on informal markets, either informal providers or drug sellers. There's an increasingly pluralistic system of production and distribution of pharmaceuticals. We've heard it, sort of, but haven't quite, with producers and distributors in varying relationship to regulatory frameworks. We know there are lots of counterfeit drugs. We know there are all sorts of distributors. So it's a very, very messy environment that really exists, particularly in low and middle income countries. And the growth of importance is China and India as producers of drugs. And although it was said this morning, what was also said is that Big Pharma hasn't quite figured out how to work with them, and we don't know what the emergence of China and India is going to do to the regulatory regimes that we're working under. There's a spread of mass media and increasing access to internet and growth of wide variety of producers of health content for these media, including advertising agencies. Didn't hear about them this morning. Advocacy groups, we heard about them, and so forth. So there's just a lot of pumping out of information and influence. And this development of regulatory framework has lagged behind. In fact, many countries have thought they were still creating a government-led monopoly system, and the rest was seen as kind of at the edge. And I have to say this morning, those enormous markets were not really very prominent in the discussion. So in Bangladesh, a couple examples, and I just have to be careful of time. In Bangladesh, had a wonderful discussion with someone who had been in government, but told us, Bangladesh has terrible coverage figures for universal health coverage, but better health outcomes. Maybe it's nutrition. Maybe it's the 200,000 village doctors who are essentially informal providers who certainly prescribe 2 or 3 antibiotics and steroids for a child with a fever and a cough. They don't die of pneumonia, and they will probably give IV saline solutions for diarrhea so they don't die of dehydration. So they're there, but they're not seen by the government. Although when I spoke to a large drug company, they had a database of 150,000 of them who they were seeing regularly. So they're not there, but they're there. In Nigeria, patent medicine vendors are the major providers of anti-malaria drugs. There are different kinds of distributors, but in many states, open markets that are essentially the distribution mechanism for drugs. And there are major problems with counterfeits. So there's a very, very messy market. sources of knowledge and influence. I mean, the point is that the users of drugs are getting information from advertising, from government messages, and increasingly now from the internet, from mobile telephones. And the producers are getting it from them, and the salesmen from the drug companies, etc. So a complicated knowledge economy that is actually sustaining this market. I guess the other point, I can see what I've done. There's evidence. I think the main thing is, though, compared to the year when I started in primary health care, there's basically a wish by almost everyone to get access to modern medicine, and a wish and a search for it, a wish to pay or to organize around an entitlement. And I think what we have to think about is, how did this happen? Because we're talking about pharmaceuticalisation. Well, governments and donors played a big part in creating these markets. They trained the village doctors in Bangladesh, who became the village suppliers of health services. And in many countries in Africa, before we trained village doctors, and now there's an enormous push to train community health workers who will mainly become the drug sellers of the next 10 or 15 years. We created big campaigns to teach people that injections are a good thing. And we created all sorts of messages that people should use drugs and are entitled to drugs. It's not surprising that people now really want them. And where there isn't a very ordered environment, how that's generated very complex, disorderly markets to meet these demands. So, what does this mean if we start thinking about global health? Because I guess that's why I said this. And how does this change some of what we've been seeing? Well, if we recognize that governments and global campaigns have been important contributors to the creation of what are essentially disorderly markets, we have to think more carefully about what donors and governments do. And the first step is to recognize the existence of these markets and recognize that we have to engage with them. Much of this activity is now outside the purview of official regulatory agencies. It's seen as corruption or a bad thing, but nothing much can be done about it. It's one of the main reasons, of course, why we're getting the emergence of antibiotic, antiviral resistant organisms, because all of these products are being distributed through these markets. We need to define specific public interest priorities. We can't try to imitate the 20th century regulatory system. I think of China, where I visited, where people interpreted essential drugs lists as the minimum number of drugs that a health facility should have, but where you have enormous problems of corruption, of counterfeit drugs, of multiple use of multiple antibiotics plus steroids for a fever, people taking partial doses, many practices that are just so obviously undesirable, where because you can't regulate everything, we're not regulating what's essential. Government enforcement capacity is limited, so we see in Nigeria the National Drug Council is attacking very much the problem of counterfeit drugs, but can do almost nothing about most other prescribing practices. But if they could just control counterfeit drugs, it would be an enormous step forward. We need partnerships. In the advanced market economies, the regulatory system for drugs was done in partnership between governments and large pharmaceutical companies. Now, in low and middle income countries, after people have first tried to create a state system of distribution, when they started to try to regulate, governments tried to operate on their own. And not surprisingly, they've been unable to regulate. Good, 2 minutes. But the problem is that we have interest groups. We have the doctors who are basically trying to deny the existence of informal markets. Pharmaceutical companies want to increase sales, although they're concerned about counterfeits. And I'm thinking of the scandal just a couple of days ago about what's happening to GSK in China. 2 other points. I mean, one that's very interesting is because we haven't seen the existence of markets, when we've had global initiatives to increase access to drugs, there's been remarkably little information on how to use them made available to the population. So although people were given the message that the drugs are important, they were given very little information on when they shouldn't take them or why they shouldn't take them sometimes. So we have thought that since the people were rather ignorant, they didn't need the information, and instead have created a demand for drugs without a capacity to use them well and without a health system able to be a good gatekeeper. So I think when we look at what's now and people are looking forward, what one can see, what I heard from this morning, is a lot of uncertainty about where the global pharmaceutical industry is going to go. So many things have changed. we need, the fact that we've ignored these informal markets for so long shows the importance of framing, and we need to reframe the question from simply how to create a state-led modern health system, how to engage with the markets that have emerged. So the first step is to look at what is. There are many powerful interest groups that are trying to influence the direction. Pharma companies, organized professions, and now the telecoms who are providing all sorts of information services. We need to find ways of engaging with them. We have competition, which we didn't exactly hear about this morning, between the incumbent powers and regulatory agencies and those in China, India, and Brazil. And we have to find ways to engage with them in restructuring. And in the end, the pathways of change are very influenced by politics. And I think what we really have to be thinking about is the politics of change in these pharmaceutical markets.
Thank you.